All right, what about now? All right, yeah. All right, Dr. Tano's in. Hi, Dr. Tano. You're muted here. I can't hear you.
How are you doing?
Okay, there we go. Well, we're having the time of our life. How about you?
All right.
That's quite a logo you got back there.
Yeah,
So,
that's the Tire Pro logo.
mhm. So did you make that yourself?
Yeah,
So, okay, so got a few minutes. We'll let everybody in, and thank you for being with us again. And please hawk your course.
okay, let me load it up.
Okay.
So do you want to make him co-host?
Yeah.
Yes.
It's clear. Everybody sees it now, right?
Yeah. Very good. This is a new book?
Yeah, this book is gonna come out soon, probably by next month.
Mhm.
Mhm.
Okay, yeah, I hadn't seen this one, so.
Yeah.
Okay, I'm getting closed caption under here, so every word is showing up. You getting it on your screen too?
Yeah, I see the closed caption. Mhm.
Do we want to keep that? Sure how to shut it off, kind of how to turn on. Controls. Okay, I trust all is well in your world, right?
Which one?
Well, in your world, everything's going well?
Oh, yeah, everything is well. So far.
Did you make any more progress on your the courses that you were looking at?
Yeah, I'm working on it. So yeah, definitely I will fill out the CME stuff and then we can talk.
Okay, great. Okay. I don't know if Dr. Robin's going to be on tonight. She's been working on one too that we've been helping her with.
Right.
So. So we're able to get you the contact information now too.
Mhm.
Huh? I think I just hit deny. I can't remember.
Okay, I got it. Okay. It says, grant access to this application and security and privacy preferences located in system preferences. I think you're already recording it.
Yeah, we're recording. Okay, so a couple more minutes and we'll be ready to go here. Yeah, we've been getting pretty good crowds lately, and which is nice.
Right.
So, and so just about 5 o'clock. So I hope everybody remembers Dr. Tano. He gave us a great talk on integrative immunology, and he's back with a little bit more information today. So it's about 5 o'clock. Dr. Tano, you want to introduce yourself again, just so everybody, folks who don't know who you are?
Yeah, very well. Thank you very much, Dr. Bill. Actually, those of you who were not on the last talk, Dr. Benoit Tano, I'm an allergist and immunologist, but I carved out my own field of study called integrative immunity. I finished my allergy training at Johns Hopkins. And from there, I taught at the University of Texas as an associate professor of medicine. But while I was in Texas, I went to a meeting that changed my whole trajectory. And the meeting was the Pan American Allergy Society, a group of ENT physicians and general practitioners such as yourselves, who meet every year, and they learn how to do skin testing, and then they introduce allergy in their practices. During that meeting, somebody did a presentation on hormones and how hormones do this, hormones do that, and stuff. But I had no idea. So, wow, why didn't I learn this in medical school? Why didn't I learn this in residency? Why didn't I learn this in fellowship? Now, why now? And first of all, this group learns allergy in 5 days. Maybe I should go and read about the hormones and try to understand it. So the more I read about the hormones, the more I found out that they were really clear in terms of many of our allergic reactions. As you will see today, many of the allergic reactions that we treat may have their etiology in hormonal imbalance. But because allergists are not really looking at that, they think that we have a dichotomy of field where endocrinology is separate from allergy and immunology. So we don't really look at the hormonal aspect of it. And so I wrote a little book called The Allergy Detective, Allergic Rhinitis Treatment Secrets Your Doctor May Not Tell You, to explain my understanding of how hormones affect allergies. And from there, I branched into obesity. Now, could the obesity that we see around be due to hormonal imbalance? And where is the hormone imbalance coming in? So I wrote another book called Hormone Imbalance Syndrome, America's Silent Plague. And that I explain clearly how environmental toxins are actually killing us all, and they're causing a hormone imbalance that is leading to obesity and the majority of the chronic diseases that we see around. So I have continued in that same pathway to further more that understanding. And last time when we met, I think I did talk a little bit about quad pandemics and the fifth state. The quad pandemics is that we have an estrogen pandemic, and we have the obesity pandemic, and we have the allergy autoimmune pandemic, and we have the anxiety depression pandemic. And the fifth state will be the bacteria virus candida pandemic. Since we talked last, maybe many of you have heard about Candida auris. Candida auris becoming one of the threats of drug-resistant candida that we're going to have worldwide. And the CDC, I knew about that. The CDC was worried about it. If you went to the CDC website, you will see the bacteria and viruses and the protozoa that the CDC is afraid of. And Candida auris was one of them. And that's how I picked it up. And that's where I put the Candida pandemic in this whole thing. The title of the book that I will be publishing next month, which is here, Integrative Immunity, Quad Pandemics of the Fifth State, here it includes bacteria, virus, and Candida pandemics. On this one, I didn't have it yet, but I do have that now. So that's where we are, and we're going to continue because I think last time we only had 1 hour, and I didn't really finish the whole thing and explain clearly towards the end. We had to rush. So I wanted to make sure that we can cover a little bit of immunology and allergy this time, so that you get an understanding of how toxins and all of these affect our immune system and autoimmunity. So before we go, I would ask if anybody had any questions, those of you who were able to either listen to the last talk, or who after the talk went and listened to the video, if you do have any questions, I would like to entertain that question right now, because I don't want you to be lost. So then when we go through it, it becomes easier for you to follow. So if there's any questions at this point, I would like to answer those questions before we go forward.
We got it all, Dr. Benoit.
All right. So I'm going to zoom through, I'm going to go through this and we'll go towards the end. As we go through it, you will see what we have covered. So the therapy book references, so these are the 4 books that I have. One of them, which was a bestseller on Amazon, The Layman's Guide to Integrative Immunity. And then we have the Allergy Detective, Allergy Prenatal Treatment Secrets that Dr. Benoit tell you, and the Hormone Imbalance Syndrome, America's Silent Plague, and the Nasal Allergy Treatment Roadmap. Now, the quad pandemics is going to come out, as well as another book that I have written for the estrogen-free lifestyle, because I think we have an estrogen pandemic. And the estrogen-free lifestyle, hopefully by the end of this week, it will be published. So we have a couple of books coming out. I think we have an estrogen pandemic. And how do I know that? Well, I think I told you last time when we met that the CDC is actually measuring chemicals in our blood and urine. And majority of the chemicals that the CDC is finding in our blood and urine, they mimic estrogen. So if we have a plethora of chemicals in the environment that mimic estrogen, and those estrogens are causing disease, then I think we have an estrogen pandemic. It's worldwide. It's not only the US, but it's worldwide. Even in third world countries, for instance, if we take a glyphosate, which is a major estrogen compound, if you go to the third world countries like Africa, you will find in a little store in Africa glyphosate that they're using to kill weeds. Well, there is even more dangerous because people have no guidelines in terms of how to use those chemicals. And in the end, they end up killing themselves because they go and just dump in the fields. And cancer rates in Africa has gone up tremendously. But nobody's doing epidemiological studies to find out why cancer rate is going up. So every time things happen, we just wait until the last minute. Nobody's really looking at it, but they're not studying it. They know that prostate cancer has gone up, breast cancer has gone up, many of the female cancers are going up, but nobody's really looking at it from that fashion. For instance, if you look at fibroid tumors in women, young women age 23 or so, they already have big fibroid tumors like the size of grapefruits. And you wonder why the young women now are having such big fibroid tumors when they didn't have before. I think it's the estrogen pandemic doing it. So from here, the CDC report, if you recall, I showed you that majority of the chemicals, either they kill the thyroid, so the thyroid endocrine disruptors, and many of them mimic the estrogens. So I showed you this table where you can see that the groups of the compounds found in the blood and urine of Americans that they sampled, actually majority of them mimic estrogen. So if you look at this big group, the majority of these chemicals are all estrogenic. And if you go down, you see that we have more estrogen. So that is what is happening. So if you have too much estrogen, then what? Find out that if you have too much estrogen, the insulin goes up. And when insulin goes up, many people crave sweets, or if inadvertently they eat sugar-containing things, then the blood sugars go up. Now, the insulin is the #1 fat maker. So what it does, it takes the excess sugar and puts it into fat cells. Very simple mechanism. So since the mid-1990s, when we introduced the GMOs in our food chain, all of a sudden we have this obesity that we cannot curb. Now, many people think it's calorie in, calorie out problem. If we ask the CDC, the World Health Organization, they all think it's calorie in, calorie out problem. But if it were so, in the United States alone, obesity would be uniform, but it's not uniform. If you look carefully and you look at the obesity maps, obesity is concentrated in the middle of America, from the upper Midwest all the way to the Mississippi and Bayman states. And it turns out Mississippi is always the driver, followed by all the states around Mississippi, Alabama, Louisiana, Kentucky, West Virginia, and then goes upward like a tree. So every single year, Mississippi starts. Now West Virginia and Mississippi are competing. And I always ask, why West Virginia? Well, it turns out West Virginia is one of the most polluted states as well, due to the coal mining and burning of coal with mercury in the air and all of those things. Definitely, they're causing much trouble. Now, this diagram here, we went through it before. I think that not only we have the estrogens causing so much trouble, but glyphosate, which is Roundup, affects a lot of things, including the thyroid. So the glyphosate affects the aromatic amino acids. And if I ask you what are the aromatic amino acids, you know that phenylalanine is one of them, tryptophan is one of them, and tyrosine is one of them. So it's no surprise we have so many people who have now anxiety, depression, they have Hashimoto's, they have Graves' disease, they have all of that because this glyphosate is reducing the phenylalanine, the tyrosine, and the dopamine, the tyrosine and the tryptophan. So if it's doing that, then thyroid is not going to work. We're going to have mood swings because dopamine is not going to be there. We're not going to get norepinephrine or epinephrine. So we have the neurotransmitters that will be disrupted. And then we have all of these other ones. We did talk about the anxiety, depression, and I showed you that we have some of the chemicals, such as the organophosphates chemicals, that lead to the anxiety and depression. And also, many people, or many of you would know that the organophosphate may be contributing to the autism that we see around. So more problems are surfacing that we're not really looking at the origin or the source of it. So most of the time, we spend time to treat. We look at the treatments of the problem rather than looking at, well, what is causing it? What is behind it? Many people assume that we already know what is causing it, and then we start treating. We don't get results that way. Going through this, I show acetylcholine going up because our organophosphates, the acetylcholinesterase inhibitors, and so they make acetylcholine available. So acetylcholine in our blood mimic a little bit the effect of estrogen, and you can see all the things that it does. If you cross that with the estrogen symptoms, they cross a lot. So then we have anxiety and depression in our midst. So how do we test the depression, anxiety? We have the CG caps, and usually I give you also some statistics to make sure that I'm not making it up. And those statistics, I got them from the government itself. Go forward, I show you that more of these things. I showed you some pathways through which tryptophan and all of that, the neurotransmitters, disruption, how we get the anxiety and depression.
Yeah, Dr.
So-
Benoit, what are CG caps?
Or CG caps is a test that you can do in the office in 5 minutes, and you will know if somebody is depressed or not. So you ask them the question, do they sleep? So hypersomnolence or lack of sleep, the interest, if the interest has gone down, things that they find pleasure in before, they don't have it anymore. If they feel guilty about anything at all, some self-esteem problems, if they have low energy, their concentration is down, they have low appetite or too much appetite, because some people, when they're depressed, they don't feel like eating. Whereas others, when they're depressed, they go to the refrigerator and every minute and they're eating, so they gain weight. Some of the people, they'll lose weight, but others will not. And the two other things, like the PIB, which is the psychomotor agitation retardation, that you have to observe it in the clinic. When the patient comes, the PhD, they cannot sit still, and that's what you will know. And then suicidal ideation. So if you ask them and you have several of these things, yes, 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 then you know that they have depression. So quick way of testing for depression.
Just a question on this, though. So when I go through my hormone history, I mean, I can look at each one of these and say, suicidal, hopeless thoughts, that could be growth hormone, agitation, that could be too much thyroid, too little thyroid.
Right.
Concentration can be growth hormone, energy could be, thyroid. It could be any number of things, right?
That's correct, yes. And if the thyroid is not working, definitely there could be a cross between that thyroid not working and depression. That's why I was showing you in the thyroid diagram,
Right.
how people who have low thyroid also have anxiety and depression because of a tyrosine, which is the beginning amino acid to make the thyroid hormone, also helps you make your dopamine, norepinephrine, epinephrine. So if that tyrosine is not working well, and if you have low iodine, which is also another big problem we have worldwide, then many people will have anxiety, depression on top of their thyroid problems. Any other question before we go? Clarification, anybody else? I'm just reviewing what we did before, so that's why I'm going through it quickly. I think all of this, you will have it on your previous video recording. So the neurotransmitters, we did talk about that, and when we have anxiety, depression, the role of the estrogens, I think we did cover that. And then what is common among pesticides, overload, obesity, anxiety, depression, and divorce? I said, if I show you this map, and that slide is actually what is on the Part Pandemic's book cover. You can see that the area with the heaviest pesticide load corresponds to the heaviest obesity, corresponds to the places where we have more anxiety, depression, corresponds to the place where we have more divorce. And it seems to all make sense. So obesity pandemic, we talked about that. Worldwide, we have a lot of obesity going. I went through the maps and showed you how it started only in 8 states, and from there quickly spread to all the states. And then I told you to watch Mississippi, and you can see that every time we move down, Mississippi is the driver. Start Mississippi, Alabama, Louisiana, Kentucky, and then goes upward. So Mississippi start, and then etc. So there's a trend in the obesity maps. Many of us, we just look at the map and we don't really see the trend. So it's important to pick up that trend and always ask why Mississippi. And I told you, Mississippi River starts from Minnesota and then goes all the way to the Mississippi. Now, all the states in the Mississippi pathway get the obesity first, and then it goes upward like a tree every single year. So the agricultural states in the Midwest, they all have more obesity than everybody else, and then it goes east and it goes west. West tends to lag behind, and Colorado is always behind. I don't know, they have a cleaner air, they live a better lifestyle than many people in the States. So I did by decade, and you can see that we have more obesity decade by decade, and now it's out of hand. I don't know how we're going to get rid of it unless we do a very big overhaul of our agriculture and industries that use those chemicals. I showed you the obesity types and then went through it. The HIPS type, which is due to too much estrogen, the ventral type, and the HIPS type, which is a combination of estrogen, cortisol, and all of that. And then obesity at deux, like folie at deux, people who live in the same household, like husband and wife, they're not in the same gene, but when you look at them, they have the same shape. So I call it obesity at deux. The kids, they're eating the same thing, they're doing the same thing, they have obesity at deux. And then we go forward and we talked about why obesity is so important, diabetes and hypertension, all the babies that obesity brings. That's why obesity is so important. I think if we spend more time understanding what is causing it and treated obesity as a disease, like the AMA once said, perhaps we will get more results with all these chronic diseases, but because we're not doing that. So I have another book coming. I call it Prison Economy. Actually, the book is already published. I call it Prison Economy. So those of you who know about the prison, the way it works, so prisons in the US, the food is so bad that if a person gets in jail, within a couple of months, they gain a lot of weight already. So if we want to gauge how bad the food is and how bad the food causes obesity, we have to look at the inmates population in the US, and you will see very quickly that there's something wrong with the food that we eat. Anyway, so what is the root of the world obesity pandemic? Let's talk about chemicals and already that, so we talk about that, we went through it. Endocrine disruptors, went through it, I give you a little history of that. And then I showed you the maps where I put the obesity maps and the pesticide maps together and showed you, for instance, if you look here, you can see the red means bad, means too much pesticides, and it's streaking through the Mississippi River. This is only one chemical, atrazine. You look at that, it's streaking through the Mississippi River, all of them. They go through the Mississippi River, and the USGS actually created these maps. And you can see why Mississippi is the driver, because everything ends up in Mississippi. And then more maps that I showed you and went through it. And then we talked a little bit about the allergy and autoimmune pandemic, immune complex. So today we're going to talk a little more about that. I did go over the environmental working group, the Dirty Dozen. In the end, I said there's no such thing as Dirty Dozen. We do have Dirty Thousand, because in their Dirty Dozen, they don't include peanuts, and peanuts are dirtier than many of the foods. Why? Because peanut is grown down south, and down south they grow cotton. And cotton requires 3 times more pesticide than any crop in the nation. So the kids are having peanut allergy. Why? Because of the chemical that we're using. And our peanut is so dirty that the European Union and Israel, our best allies, are not buying our peanut anymore. They're buying the peanut from Argentina. So you wonder, what are we doing? But when we go to allergy meetings, we don't necessarily talk about this peanut allergy and why and what. We talk about the peanut protein. If you notice, since the mid-1990s, we do have also a number of people who have gluten sensitivity. And every time we talk about gluten sensitivity, we talk about gluten protein. We never question why we ate bread for 1,000 years, we didn't have any problem, and now all of a sudden, in the mid-1990s, we eating bread and we cannot tolerate it. There must be something that we're doing to the food, to the bread. That's because the farmers discovered a lot of practice for pre-harvest Roundup spray. So before they harvest the wheat, they spray Roundup on it. And so that goes directly into our food chain. And that is what is driving the gluten sensitivity. So here I show you that, for instance, an anaphylactic reaction was going down in 1997. We introduced a Roundup on a larger scale, 1994, 96. 1997, let's say that there's a lag effect, but at the sudden, this anaphylactic reaction has gone up tremendously. If we look at the angioedema, which is lip swelling, facial swelling, and all these, it was flat right here in 1997, it went up. And all of these, I got this diagram from the HCAP database I created from the HCAP database. So I didn't make it up, the government database, that's where I got this from. Anaphylactic reaction to peanut, it was not bad right here in 1997, you can see a trend upward. If you look at celiac disease, it was even trending down 1996, 97, start going up. If you look at glyphosate Roundup versus celiac disease, and this is Nancy Swenson and colleagues who created this map, but you can see that they track really nicely that the higher the glyphosate, the higher the celiac disease. Now, if I take things such as crustacean allergy, you cannot see that trend. Fish allergy, you cannot see that trend because it doesn't depend on pesticides. If you look at iron deficiency anemia, definitely there's a trend. It was flat right here in 1997. It went up astronomically. Now, those of you who do test for iron stores in your patients, you test for ferritin, or you can see that many people have low ferritin. Now, why? Why all of a sudden we have so many people with iron deficiency? Now, many people, they don't, when they test iron, they don't test the ferritin, they test total iron and stuff. It may look nice, but the iron stores are low. So what do? You stop there and say, okay, well, you have plenty of iron, I'm not going to give you any iron. No, they don't have any iron stores. And I showed you also that if the iron stores are low, then they're going to have low thyroid. And they're going to have anxiety and depression. They're going to have all of these things. So there's a lot of things that we're not looking at that may contribute to some of the pandemics that I was talking about. I always give you the statistics. You can see urticaria, for instance, is more common in women. And why? Because I will show you today later estrogen receptors and stuff. Glyphosate induces human breast cancer cells. This is an article that was written about that. Chemicals in our food production. I also went through it and showed you plenty of chemicals that we put in wheat. It's not only Roundup, glyphosate that we spray in wheat, but we're using all kinds of other chemicals, the organophosphates, and many other chemicals in wheat production. I classified them, what they're doing to us, so you can see it. The virus, bacteria, Candida pandemic, we talked about that. And you can see that we have drug-resistant bugs that are growing like weed. And it makes sense because we know many of these bacteria and Candida and virus, they all proliferate because of sugar, glucose. But a person who is obese will have more glucose. And anybody who, if we have more obesity, we're going to have more glucose around to feed all these bugs. So then they're growing in us and we cannot kill them. We're also using tons of antibiotics in our food production, and then they become resistant to the antibiotics, and we cannot kill them. So in the end, we will be the losers of this whole battle. And that's the big diagram I think we ended up with, where I showed you the house, and then I constructed the house very slowly, step by step, to show you how too much estrogen affects the obesity, affects the thyroid, affects a lot of stuff. And so this diagram, if you know it, then it would allow you to really take care of the patient nicely, because you can see that all the chronic diseases are connected in one way or the other. And then I will go through it very quickly so you can see how all these things we fill it out and went through. And just gonna fill it out. Many of you who use supplements, all the blue ones will be for every situation, all the supplements that we use. So I'm going to continue today. It's a quick review of what we did last time. And to continue, I will tell you that the estrogens, because we have an estrogen pandemic, these estrogens, they have receptors on your mast cells and basophils. So when we go to the next diagram, you can see that the estrogens come here and they have receptors on your mast cells and basophils. It's called the estrogen receptor alpha. So when they're attached to the receptor alpha, they cause histamine and leukotriene release, just like polynarvepin would, that they make the effect of the IgE stronger. So that's why we have so many people who do have allergies. And many women now, they're showing up with allergies that they didn't have before, because they already have more estrogen than men. So now, when they eat certain foods that are estrogenic foods, then they're reacting. In the allergy world, when we test these individuals who are reacting to estrogenic food, the test that is based on IgE testing is negative. We don't find it. So we say, well, you don't have allergy, we don't know. Now that's a different pathway through which people are getting the allergy. They're getting through the estrogens, and maybe through the organophosphates, through a lot of the other stuff that I talked to you about. So we should not stop in allergy testing. We should not stop just at the IgE. We should look at many other factors. So let me go through this diagram for you. Antigen-presenting cells, which are your macrophage, monocytes, and dendritic cells, I call them patrolmen. They're like the policemen of the body. They pick up all the allergens, whether it's pollutions or food that are contaminated, and then they show that to their friend here called Th0 cell. That Th0 cell, I call him Superman. Why? Because he can go to Th1 or Th2 or even Th17 or many Ths. When he goes to Th1, it signals to the B cell that are called bomb-making guys, because these guys are the ones that make the immunoglobulins. And those immunoglobulins, so the B cells then go into plasma cells. I didn't put the plasma cells here, but Th1 signal to the B cells become plasma cells. And those plasma cells produce the IgG, the IgM, and IgA antibodies, the bombs. So then those bombs then come and attach to the bacteria, the viruses, the toxins that they're trying to attack. And once they do that, then more macrophage will come in to fight it. So many of you, when you do your blood test, you will find that you have an increase in monocytes out of nowhere. You wonder, well, why monocytes are so high? Well, it could be that these antigen-presenting cells are high in the blood, they're fighting some toxins. So that person that you're looking at could have a toxic overload. And if they have a toxic overload, you have to clean it up. Certainly these days we are in a better place because we do have detox products that we can use to detoxify individuals. So that's a major one. Now, the antigen-presenting cells, if they pick up allergens such as pollens or dust or mold or pet dander, then show that to the Superman, and then now he goes to Th2 to try to fight the allergens. So the Th2 will produce alpha-13 that then will stimulate the B cells, the bomb-making guy, to make IgE. So that's where the IgE comes in. And they make the IgE that circulates and goes to attach to the mast cells and the basophils and waits. So next time when the person goes to breathe pollens or dust or mold of around animals that cause the allergies, then that protein goes into the bloodstream quickly and find the IgEs that are specifically made for them and attached to it. So a cross-linking of these things occurs. That is like a signal for the bomb-making, for these masses and basophils to explode. And when they do, they release the internal contents that cause trouble for us. So the number one content they release is the histamine. And the histamine is the nerve-ending irritant cause itching. So people start having the itchy eyes, itchy nose, itchy throat, they sneeze in the runny nose. And to block the histamine, that's why we do the antihistamine. Of course, you do have many of the antihistamine, I use the brand names here, diphenhydramine, loratadine, and etc. So Benadryl, Claritin, Clarinex, Allegra, Zyrtec, and Zizol. So those ones will help. Many times what I see in general practitioners is that if somebody is having allergies, they give them just the antihistamines. And they don't know which antihistamine is even stronger. For instance, you know that Benadryl is fast acting, but it's not as strong as even Zyrtec. Zyrtec is one of the strongest antihistamines. So if somebody is having a reaction, you can give them Zyrtec. For instance, if somebody is having hives, you can give them Zyrtec, but one Zyrtec may not cut it. So in the allergy world, we say, well, you can give them up to even 4 Zyrtec a day. So 40 milligrams instead of 10 milligrams will be enough. But many times we give them just one and we think it will cut it. If you get people like pilots who come to your office and they're having reactions, are you going to give them Zyrtec? No, because if you do that, they can crash the plane. So you may want to give them fexofenadine, which is Allegra. Allegra is potent more than loratadine, which is Claritin. So Allegra will be second in line after Zyrtec. So if somebody cannot tolerate the sedating antihistamines, if they cannot tolerate the sedating antihistamine, then you can give them the fexofenadine, which will help them. Now, some people cannot tolerate any of those at all. So those individuals, you can give them loratadine, which is the Claritin, and that will help them. Now, what I was going to say is that this may not be enough because you're not blocking all the mediators that the mast cells and basophils are releasing. So that's why your patient may not get the result. So what you want to do is look at the other mediators, like leukotrienes. So sometimes you can give Montelukast or Singulair to the patients, and it will, in conjunction with the antihistamine, and it will do a better job, especially if they're having that post-nasal drainage, they're coughing at night, they're having all kinds of wheezing. You may want to give them the Montelukast or Singulair in addition to an antihistamine that will help them with those symptoms. Now, the timing of Montelukas is very important. It's an interesting one. The local trains, they release about around 7 p.m. in the evening. So if you give them the singular in the morning, those local trains are not there. If you give them too late at night, like 10, 11 p.m. at bedtime, then you play and catch up. So what you want to do is to make them take the singular about 5 to 6 p.m. around dinner time or supper time. So by the time the local trains come in, then they're blocked. So that's what I tell all the patients. The patient will come and say, wow, since I changed my timing, actually I have better results than when I did take it at bedtime or I took it in the morning. Now, there's a warning about singular causing depression and all of that. So some of the patients will tell you that if they're truly having depression symptoms and stuff, then you may not want to give it to them, but we give it to children, we give it to adults, and they don't have reaction. So I really don't hesitate at all to give it to a patient if they need it. Now, the master block of all these chemicals is steroids. That's why many people who have allergies, we give them nasal corticosteroids. The nasal corticosteroids, now we have Flonase, and we have Nasonex, we have Nasacort, we have all of that. The most potent and interesting one would be Nasonex, and now it's over the counter. So the patients can buy Nasonex over the counter, and it will help them better. Now, Flonase has a fluorescent to it. Because Flonase has a fluorescent to it, not all the patients can tolerate it. Many of you have noticed that we have a more and more patients with multiple chemical sensitivities. If they do have multiple chemical sensitivities and you give them Flonase, they may have a reborn congestion. So that's why it's important to ask them this. Your history taking, you may want to know about the allergy history and see if they do have any chemical sensitivity. If they do, don't give them Flonase. You can give them Nasonex that may help them better. Also, the way the nasal spray is done is very important, because I realize many times we don't teach the patient how to use the nasal sprays. Guess what? The patients are drinking the nasal sprays. If they drink the nasal spray, how do they get results? They will not get results. So if I ask many of you, how do you do nasal sprays? I can tell you, many of us don't know how to do it. So I always try to tell people how to do it. So you put the head down, you put in the nose, and then you push away from the nasal septum. And when you push it away from the nasal septum and spray in the nose, you don't sniff it out, because if you sniff, guess where it goes? It goes straight to your throat. You're drinking it. So no sniff. You have to pat the nose up and then leave in the nose. And you do the other side, you push away from the septum, you spray in the nose and pat it up. Now, the reason you avoid the septum, that's why the blood vessels are thinner. So if you shoot too much on the septum, it will sting, it will burn, it will bleed. So you have to avoid the septum at all costs. That's how we do that. Anyway, that is for the medication. Now, when somebody has an anaphylactic reaction, we give them antihistamine. Most of the time we give them Benadryl because it's faster acting, like I said. But if they go to the emergency room, or if at home, we give them an EpiPen. Why do we give them the EpiPen? So the EpiPen is going to help them to not continue the reaction. So it will help them stop it. But many times the reaction continues. So that's why when they give themselves the EpiPen, they have to go to the emergency room. And when they get to the emergency room, sometimes they give them more EpiPen, and then they give them steroids. Why do they give them a steroid? Because the steroids will block all these mediators. And that's why they do that. It's very important to know that. Anyway, when it comes to multiple chemical sensitivities, there's another or some other medication that would be useful, such as Astelin. And the Astelin, you can use it and it will help control some of those multiple chemical sensitivity reactions. Dimista, which is a combination of Astelin and Flonase, is a newer one on the market and it's more expensive. So some insurance companies don't want to pay for it. So you may want to give them the separate ingredient, which would be the Astelin and the Flonase of Astelin and Nasonex, and they would do better than if the insurance company doesn't want to pay for it. Now, in order for us to know what is going on with this patient, that's why we do the skin testing. When we do the skin testing, if they have pollen allergies, normally the spring is their problem. So they have spring allergy, you will find trees. If they have summer problem, will be grasses, and for the fall, it's the weeds. And perennial allergies will be cats and dogs and dust mice and moles and horses and all of these things. When you find that they have an allergic reaction to all of these, then you can do the allergy vaccine. The vaccine will incorporate everything that they're reacting to, and either we inject it or we can give them sublingually. But why do we do it? Well, when we give them the allergy vaccine, somebody sees it, and it's the T regulatory cells and the B cells that pick up those vaccines. And when they do that, they produce some mediators that will also block it. So IgG subclass 4 and IgA will be produced by the B cells, and then the T regulatory cells will produce IL-10 and TGF-beta. Those are the ones that will come and block the pathway between the Th2 cells and the B cells. But also these will come and block the release of these leukotrienes and histamine and prostaglandin, so then the reaction stops. So in the long haul, 3 to 5 years, which is the time recommended by the Allergy Society, is what we give them the vaccine for. And then in the end, they don't react that much. Many people, or some, they don't react at all. Some people who cannot tolerate certain foods and may be able to tolerate the foods if you do that. I think, this is the mechanism behind allergic reactions, and I think we went through it. Now, sometimes if you do allergy vaccines or you do allergy medication, it does not cut it. Why? Why? Because all we're doing is blocking the IgE-mediated reactions. Like I said, if they have estrogen reactions, which is now the bulk of women reacting to foods and things like that, then you have to test their hormones and fix their hormones as well. Because if you don't do that, then the allergies will not get any better, no matter what you do. So you have to look at the whole thing, the whole picture, and that's where integrative immunity or integrative medicine or functional medicine comes in the allergy world, where you can cross and test for the hormone problems. Now, for food allergies, it's exactly the same thing. Now, I think that our foods are contaminated. And since the foods are contaminated, before the patrolmen, the antigen-presenting cells, they used to see clean peptides, clean foods. So when they're like controllers, when they see the clean peptide, they say, oh, this passes, this passes, this passes, this is good. However, when they see the dirty foods that are contaminated, they say, oh, this is danger sign, let's do something about that. So when they pick it up and they show that to Th0 cell, the Th0 cell goes to Th1, creates the antibodies, and the antibodies come and attach to those chemicals or those bad stuff that they don't like. Now, antibody-antigen complexes circulate in the blood, and many times they lodge in the small vessels and form inflammation. And that inflammatory process is what we call autoimmune disease. Because it's continuing, they get inflammation and they get reaction, then we say autoimmune disease. Now, autoimmune by definition means that our body went crazy and it's attacking itself. I always say that the body, it does not go crazy. The body is smart. The body is not attacking itself. The body is attacking something that it does not like. That's why I don't talk about autoimmune disease. I talk about immune complex disease. The immune complex is the antigens attaching to the antibodies and form complexes that cause the reaction that we call autoimmune disease. Now, of course, the Th0 cell can go to Th17. Some people see that pathway as a pathway to autoimmune disease. But the same scenario when we have contaminated food and we make all these antibodies, sometimes also we make the IgE. And when we have the IgE, same reaction occurs, and then we're going to have histamine release leukotriene. If tons of histamine is released, that is a vasodilator. So the histamine is going to vasodilate, and so blood pull from the head, if nothing is done, people can pass out and die. When we give the EpiPen, it's a vasoconstrictor, and that the EpiPen is going to constrict the vessel so then people don't pass out and die. So that's the only reason we give them the EpiPen. Here again, I'm seeing more and more women and children, or even who are having more reaction to estrogenic foods. And they have reaction to the estrogenic foods, and we do the allergy testing, it's negative. We do skin testing, it's negative. We do IgE testing from the blood, it's negative. We say, well, you don't have allergies. What they do? They don't have allergies, why they're reacting. But they have a non-genomic pathway through which they're reacting. They're reacting to the estrogen receptors. They can react through the they can react through the acetylcholine receptors. So the mast cells and basophils do have more receptors than we think, and I'll show you those receptors as we go. So when it comes to vaccine, we cannot do the subcutaneous immunotherapy in terms of vaccine for foods, but we can do the sublingual immunotherapy in terms of vaccine for food. And we do that chronically in or regularly in our clinic, where we do food allergy testing and we do sublingual immunotherapy. So those of you who may be interested in doing that, you can always contact me, and then we can help you introduce allergy in your practices. I think Dr. Bill is going to talk to you a little bit about what we're planning to do in terms of presentation. But I think we have a workshop that we're going to bring soon. And the workshop will go for 3 days, where we'll go in detail about all of these things and show people how they can introduce allergy in their practices and things like that. Mast cell activation syndrome. That's the big conundrum that we have in the 21st century. Now, the patients are getting worse and worse in terms of the allergic reaction. And no matter what we do, we cannot get them well. So those patients are very distraught because it's difficult to treat these patients. For instance, big clinics such as the Mayo Clinic don't want to see them anymore. So they're time consuming. They will come and they have all kinds of things. They have POTS, they have EDS, Ehlers-Danlos syndrome. They have all of these things that they're showing up with in clinic. And you wonder, whoa, what are we doing now? So if you go to concentrate on those patients, you can see only a couple of them a day. And if insurance will have to pay for it, then you cannot see more patients, then you're going to be out of business. So that's why the big companies don't want to see them anymore. It will be important for us all to understand this whole thing very nicely and see the triggers so that we can treat them better. Now, they will come with symptoms such as skin rashes, hives, swelling, edema, flushing, itching, abdominal pain, nausea, vomiting, diarrhea, wheezing, shortness of breath, heart palpitations, anxiety, difficulty concentrating, headache, brain fog, low blood pressure, fatigue. I mean, you can go on and on and on and see all the things that they show up with. Disease associated with mast cells, we have allergic disease such as asthma, autism, autoimmune diseases, pemphigoid, eczema, celiac disease, chronic disease, all of these, the mast cells can cause that. So it looks at how many of you have seen many women showing up with interstitial cystitis. That's a mast cell disease. Even the urologists, they know that. They think that the mast cells, they aggregate in the detractor muscles of the bladder, and they cause the irritable bladder called interstitial cystitis. Back in the old days, when somebody showed up, it's a diagnosis of exclusion. So, we don't know what to put these people, put them as interstitial cystitis, I see. And now we know what is causing it. It's the mast cells that are causing that. So if you want to treat it, then you can do that part. So postural obstructive tachycardia syndrome, a lot of you are seeing this in clinic. So how do you address it and what do you do? So I'll show you the mast cell and the receptors on the mast cell. So the mast cell, they have the sodium channels. They do have the estrogen receptors. They have acetylcholine receptor. And they're having mediators that they're releasing. So if we are exposed to all the chemicals in the CDC 434, wouldn't you think that we get more reaction with the mast cell degranulation? Because all these chemicals having receptors on the mast cells, they're going to trigger the mast cells to proliferate and to release their chemicals. I think last time when we met, I showed you that insulin causes the mast cell to proliferate. Insulin resistance is one of the things that we have in our midst due to the estrogen plethora that we have. So when we have too much estrogen, we get insulin. When we have too much organophosphates, we have insulin. And those chemicals are plentiful in our environment. So in the end, we have tons of mast cells, and we have many more chemicals causing them to degranulate. And when they degranulate, they're releasing the mediators, and I showed you only a couple of them in the previous diagrams. And now you can see all of these mediators that they're releasing. And many of them are inflammatory mediators, cytokines. And those inflammatory cytokines are going to cause reaction. So a lot of people are having reaction. For instance, when we have COVID, we did say that who dies more? It is the obese individuals. Well, why? Because they get a cytokine storm. Why do they get a cytokine storm? Because the mast cells are contributing to it, leading to the cytokine storm. And so because they will be releasing many of these cytokines, and since the obese individuals, they have IL-6, they have TNF-alpha that they're releasing already from the fat cells, and they're causing inflammation. When it couples with all these mediators released by mast cells and basophils, then individuals end up having a cytokine storm. I will also show you very soon IgG, the effect of IgG in the mast cells. So the mast cells, they have IgG receptors. And when the IgG is attached to the mast cells, they cause them to release their cytokines. So when we get exposed to COVID or viruses or bacteria, and the B cells are making IgM, IgG to try to fight those bacteria and viruses, that IgG does not stop there. Not only will go and bind the bacteria and viruses, but it will also go and attach to the mast cells and basophils. And when it does that, it causes them to release their mediators, and then we're going to have more inflammation, cytokine storm, and people will die from it. So that is the connection. Mast cell activation syndrome, going backward. So again, what I was saying is, when you have bacteria, viruses, and stuff like that, your toll-like receptors are going to be activated. That will lead to mast cell degranulation. If you have IgG, that IgG is going to come and stimulate the mast cells and lead to degranulation. If you have complement, so what stimulates the complement? Now, when we do the workshop, probably we're going to go through the complement pathways so then people can understand the whole thing. That complement is pathways are stimulated by antigen-antibody complexes, and that will lead to the complement sub things like a C3R or C5R, a C5A, and when these guys attach to the mast cells, they cause degranulation. So you can see how the mast cell can be degranulating, not only due to IgE, but also the IgG, the complement pathways and stuff like that, that will lead to more reactions. Now, these are more receptors on the mast cells and the basophils. Now, you can see the Fc epsilon receptor 1, that's the IgE receptor. And then you can see the Fc gamma receptors, which is your IgG receptors. You can see many of the inflammatory cytokines, they have their receptors on the mast cells, VEGFR and all of these other things, they have receptors, the toll-like receptors. All of those things will cause the mast cells to degranulate. And that's why the mast cell is not just a benign white blood cell. It does a lot of things that cause more problems for many, many people due to the fact that they have all these receptors on their surface. Basophils, they're the cousins of the mast cells. Back in the old days, we used to think that the mast cells are the same as the basophils, just like monocytes and macrophages are the same. We think the mast cells and basophils are the same, but it appears that they're different because it's not the mast cells in the tissues and skin that become basophil. The basophil, they live in the blood, and the mast cells live in the tissues and the skin. So they have the same, almost the same mediators, and they release the same mediator. They have the same receptors. So many people who talk about mast cell activation syndrome do not talk about basophil activation syndrome. Here, I think we can go over and talk about basophil activation syndrome. It's the same chemical that activates them, and estrogens are part of it. That's why so many people, women, are activated. Many women have mast cell activation syndrome than men because they have an underlying condition, which is the estrogens. Too much estrogen compared to men, therefore too much reaction compared to men. When histamine is released, histamines affect everything. It affects the respiratory system, it affects the uterus, it affects the gastrointestinal system, it affects the central nervous system, it affects the cardiac system. So in the end, all the reaction that we're seeing may be related to the histamine that is released by the mast cells and the basophils. So it's important to know that. And then when you talk to the patient who have mast cell activation syndrome or basophil activation syndrome, it can show them systematically what is causing them through the H1, H2, H3, H4 receptors. And I'll go down and show you more of that estrogen-free lifestyle. So all of these will be in the estrogen-free lifestyle book that is coming out this week sometime, where I'll go and show how can we avoid the estrogen then? What do we do? Because if estrogen pandemic is driving many reactions, then we have to know what the estrogens are, what foods are estrogenic, How can we avoid those foods? What should we do with them? And I go in detail. I give a little bit of cooking possibilities and things that people can eat, because most of the time the patient tell me, well, you tell us what we cannot eat, but what can we eat? So in the book, I give a lot of options and what people can eat and cannot eat. I think we're right on time, and I can entertain some questions.
Okay, I have a question. And just as a patient and an asthma sufferer in the past, what do you do for, like, someone has serious asthma? And then my other question is, what's your theories on autophagy to reverse the spike protein?
Okay, so those are good questions. I found out personally, I do not use biologics, as you know, because I'm trained in functional medicine. Therefore, I tend to stay away from harsh medication. So my analogy is, why kill a small bird with that we can kill with BB guns? Why kill this bird with machine guns? Now we are inventing machine guns to kill small birds. Now, if somebody has asthma, if many of you know, they have classified them into eosinophilic asthma, non-eosinophilic asthma, and therefore, if they have eosinophilic asthma, you can give them some biologic to try to help them out. Well, the eosinophils, so just to answer your question, Lars, the eosinophils are not just coming in there for no reason. They're coming there to do something. And we all know that parasitic infection may drive a lot of these eosinophils to come around. Now, parasitic infection may not stop in the gut. It could go to the lungs. So why can't we think, well, maybe these eosinophils are aggregating in the lungs because we have some parasites in there. And perhaps we should detoxify, we should fill them up, give them self or something and clean them up or kill these parasites. So then these individuals don't need a biologic that is going to cause the immune system to be suppressed and then bring more parasites to them. So there's a lot of things that go in that fashion. So personally, when I see patients who have these kinds of things, I go beyond the general understanding of it and say, okay, what else can we do? So I have been able to help a lot of patients by addressing candida in those patients and also addressing bacteria. Now, one of the bacterium that actually causes asthma flare is Chlamydia pneumoniae. So if Chlamydia pneumoniae is a big deal, and we all know that, then why don't we treat the chlamydia and also treat the fungus that may be contributing to it? And when I do that, and I give them some basic inhalers, things get really well. They don't need to be on these immunosuppressants and all of that. So I do a lot of that, and the patient get well. They don't need to be on biologics. So I brag that I really never used any biologics. I never gave anyone Xolair. But they have a urticaria, they have hives. I never give anybody Xolair because I found out what is causing the problem. And I treat the underlying cause, and the urticaria goes away without giving them the biologics. Your second part of the question, I did not get that very clearly.
Autophagy is what resolves COVID, what helps stop the spike protein.
COVID. So the COVID, I'm thinking, one of the things that we have found since COVID came in is a lot of hives. I don't know if you're seeing that in your clinic. People who have vaccinations, people who had COVID, a lot of them are getting hives. Now, why? Well, it turns out when you get COVID, like I explained, then the antigen presenting cells are going to pick it up. That will show that to the Th0 cells. The Th0 cell will go to Th1. They're going to make antibodies. They're going to make IgG. They're going to make IgM. They're going to make IgA to try to fight that virus. So when these antibodies are made, then they will go and combine, or they'll go and attach to the virus, and that circulates and causes inflammation. That's one way. But the IgG that is made also will go, as I showed you, to stimulate the mast cell to release the mediators. And big mediators that will be released would be the histamine and leukotrienes. And when they're released, they're going to cause allergic reaction. One of the big reactions is going to be the skin reaction, such as the hives that we see around. So since COVID, we see in these hives, but people still do the old way, but we give them biologic, we don't give them Xolair, instead of thinking in terms of why. Also, women are getting more. Why? Because the women, they have several tests going. They have the estrogens overload that is stimulating the mast cells, and they have the antibodies that is stimulating the mast cells. So they have more reaction going because of the estrogen overload on top of that. That's how I can explain that. Not,
Thank you.
sure. Other questions?
Yes, Dr. Dan, this is Dr. Patel. Thank you for your nice lecture. I have a question that there was something you mentioned that for food allergy, you cannot do the intracutaneous testing with the treatment, subcutaneous treatment or SQ. You can just treat them with the sublingual drops, and you're right, but we have treated thousands of patients of food allergy and really suffering from that, and have gotten better with the sub-Q injections. And some children, those who were not parents were not able to give them the injections, we treated them with the sublingual drops. And when the sublingual drops did not work adequately, then we switched them to the injection. So I think in your own experience, it may be that sublingual drops work better, but in our experience, we can say that we have excellent results for food sensitivity and allergy, whatever you want to call, because there's a difference between sensitivity and allergy.
Right.
And we have a good response. And number two, I had a patient who received the COVID vaccination, and she passed out. She had anaphylaxis. She was transferred to the hospital, remained in the hospital. And right after that, she became exquisitely food sensitive. She was only able to eat only 2 foods, and 2 foods were for mainly the rice and boiled pork. So I just want you to give your opinion regarding this, so maybe the audience can benefit from it.
Dr. Patel, that's a good question. I personally, as an allergist, though, I can tell you, I'm not sure about the subcutaneous immunotherapy for foods. And I'm not sure what is the dosing that you're using, because allergists are very leery about giving the subcutaneous immunotherapy due to an anaphylactic reaction. But remember, many of us do strong immunotherapy, so we can give you subcutaneously for environmental allergens. Even that, for environmental allergens, people react. And that's why allergists do not give a subcutaneous immunotherapy for food because you're introducing the needle in there and you're pushing the antigen inside. That could lead to an anaphylactic reaction very quickly. People do the oral immunotherapy. The oral immunotherapy in which they're exposing the patient to the true food. For instance, peanut allergy, the children that we give them the actual peanut to eat. And that again, there's a class divide because there's a group of allergists who believe this is a dangerous practice. And I can give you some names, some of the famous allergists that even I trained with. Those people think it is dangerous to do that because it predisposes the children to have an anaphylactic reaction. And so they don't want to do that. If you tell allergists to go and do injection immunotherapy with food, they will say that's dangerous. They're not going to do that. But
Yeah, they're going to flip. They are going to flip.
Yeah, that's why.
Let me give you my background. I am a specialist in environmental medicine.
Right.
Our way of testing is we don't test them with the concentrate or number 1 or number 2. We go according to the patient history and try the more acceptable dose for personalized dose. And so
do you do the Renko method where you
we are using provocation neutralization method. We don't
yeah.
provoke, we try to give the dose and it provokes the symptom, we neutralize with the neutralizing dose. And yes, Italians have tried that.
Right.
And but Americans are still very, very resistant to it. However, they were resistant to even the sublingual therapy before.
That's correct. Actually,
And then about 10 years ago, I think it changed. And then the report from the California came from the Stanford.
Right.
So the point is that we have to, and I really appreciate all the different mechanisms you showed in our books, reversibility of chronic degenerative disease and chemical sensitivity. Between the William Ray and myself, we have 6-volume book, and we have described every single mechanism and how the chemicals are interacting with our allergy epidemic, with the estrogen epidemic, cancer epidemic, and so on. From the diseases which were like come and go, it ended up being the fixed irreversible disease. But any point, if we can intervene in between, then we can reverse the disease. And
yeah,
I think
I would
you showed
really
some
like
of
to
the
know.
mechanisms.
I would like to know how you guys do the subcutaneous immunotherapy.
Yeah, sure. If you have a course, I'll be glad to. I'll get glad to join you. I mean, I think that we have a very few practitioners and our patients, and we want to teach that to the new generation so that they can be very helpful, because our society is going to have more allergies and not less. But going to the biologics, it is killing the immune system, and an ongoing basis, they are going to develop some degree of cancer later on, because we are suppressing the system and polarizing more to the depending upon the system.
That's correct. Actually, that's why I don't give biologics, because they have their side effects that we don't see
Exactly.
immediately. Yeah. Now,
Exactly.
the second question is, this lady who had COVID, and after that, she could not eat any food, etc. I really think that she had 2 effects going, right? One of them is either toxic overload. So I have this acronym that I use, I call TOBIN. They have toxic overload, biologics, which is hormonal imbalance. They have infections, and then nutrient deficiencies. Those are all the things that drive the reaction.
But on our COVID vaccine patients, I can tell you that I neutralized her. She's able to take 30 foods. She's able to go in society. She's not reacting to chemicals.
Right.
And we have done within like little over 3 months.
Right.
So, and she is living much more normal. She used to even react to her hair shampoo and somebody's perfumes, just like multiple chemical sensitivity or sensitivity to multiple chemicals. We like to use the term sensitivity to multiple chemicals
Right.
because we don't want to be obeyed by the rules of the occupational medicine people saying that, you have to, when you say the multiple chemical sensitivity, you don't have any it's just a syndrome. You don't have any really biologic markers and the positive supported by the so I think that it may be a good idea for people to learn the difference between the multiple chemical sensitivity and sensitivity to multiple chemicals.
Yeah, it's
Yeah.
a semantic, it's you flip it around, but it makes sense. What you did is clear, right? You clean them up, so then, they don't react to the chemicals anymore, they don't react to the food anymore, so they can tolerate it. Assume that you balance their hormones, you did all the things that they need to do to clean up their body, so then they can tolerate the foods, right?
Yes, and we have desensitized, or I would say we have skin tested them with the hormones, the patients, and as you mentioned that it's more common in females, and that's so true. Then when we sit in our offices, we have more female during the testing than the man.
Right.
So the ratio is like 80-20. So I think it's important that we understand that you can really neutralize them with the hormones and make them less sensitive to them and make them more tolerable and live a normal, healthy life.
That's correct. Yeah, so definitely knowing that chemicals, the environment is part of it, and then cleaning up and because we see all these complicated patients, and many of us say, okay, let's go see endocrinology. The endocrinologist is not going to do anything for them, right?
No.
We send them to gastroenterologist. The gastroenterologist is not going to do anything for them. So you have to be able to take care of themselves, this patient by yourself. And to do that, you have to know what to do exactly. Yeah.
We take care of everybody's failures in
Yeah.
a sense.
Right.
Thank you.
Sure. Other questions? We can have a nice chat.
No, thank you, Dr. Tano. There's a couple of questions in the chat. Do short-term memory loss connected to hormonal dysfunctions by men?
Yes.
That's an easy.
Yeah, I would say yes. So again, short-term memory loss or even long-term memory loss, people with Alzheimer's, my acronym TOBIN applies, right? TOBIN, toxic overload, biologics, which is hormonal imbalance, infections, and nutrient deficiencies. So if you have short-term memory loss, you may want to address all these issues, so then memory can come back. It's not only giving people neurotropics, or what they call them, these supplements that may help their brain, like Bacova or ginseng or any of those things, but you have to be able to take care of their hormones. And testosterone deficiency is a big one. For instance, if we see patients who are broken, they cannot find words. They want to say, oh, I forgot what I was going to say. I don't know. Well, these people, they have testosterone deficiency, right? So unless you fix their testosterone, they're not going to get any better, no matter how hard you try giving them supplements. So it's always good. That's why this group, I think I'm preaching to the choir, you already know how to deal with people holistically. So you have to look at all the aspects. Dr. Bill's courses definitely would do you more good to understand how to balance hormones and help the patient. So if someone is having short-term memory loss, definitely check all these factors that I have mentioned.
Thanks for the little plug there. The question is, what do you treat anxiety and depression, or how do you treat?
Okay, so for me, Yeah, when I see anxiety and depression, again, I always go to the bottom of it, meaning what is causing it? So if you look carefully, like I said, you have to test the thyroid thoroughly, making sure. You have to test the iron, you have to test everything. You have to test their hormones because estrogen overload can lead to anxiety, depression. Organophosphate overload can lead to anxiety, depression. If they have even testosterone deficiency can lead to anxiety, depression. And what I'm finding out is, I talked to you about the prison population. You know, many people are addicted to drugs because of their biologics, because they have hormone imbalance. And those hormones are affecting the endorphin centers or receptors, and they're causing these people not to feel good, and they want to go use drugs. And it's a cycle, so no matter what we do. And then we say, okay, let's do a medication-assisted treatment. We give them Suboxone, we give them all of these things. And these patients are not doing better. Why? Because they can go on Suboxone for 10 years, and then they relapse. We wonder why? Well, because their hormones are not addressed. So it's always good when we have anxiety and depression to go beyond and look at all the other aspects of it, why we have it. Is it because of a hormone imbalance? Is it some simple situational? Because sometimes it could be situation. They are in a bad relationship. And if they're in a bad relationship, why are they in a bad relationship to begin with? It could be hormonal. It could be toxins. It could be all of that. So you have to look at all the aspects of that and be able to address the anxiety and depression. Since the mid-1990s, if you look, anxiety and depression has gone up tremendously in everybody. COVID actually made it available to us to see it, but it has been around for quite a long time now. Anxiety actually has surpassed depression as the #1 mental problem that we have in this country. If you look carefully, it's all the environmental toxins that we have that may be driving this anxiety. And we're not looking at it as such. We think, oh, it's stress. Well, stress makes it worse. Probably the stress is not the crucial underlying cause. It makes it bad, but maybe all the toxins are causing it, and we should more look into the toxins that may be conditioning this stuff. So that's why I personally, when I see the patient with that, I look at the whole picture. I detoxify them, I give them hormones, I fix their thyroid, I fix their iron levels, I give them good foods, organic food to eat all the time. I give them the nutritional supplements. So it's a lot of things that you got to do to take them off their anxiety medication.
What does a detox program look like?
Well, it depends. So there are many detox programs out there, and I personally go for the estrogen detox programs, meaning, for instance, you have companies such as Ortho Molecular, they have called Restore, that the purpose as anti-estrogen detox. You have Dr. Isaac Elias products that he uses to detoxify people. Now you have Cellcore that does the biotoxin, taking things out. So we have a lot of things that we can use to detoxify people these days compared to before. So more and more people are getting into it to try to do the detox.
Okay. Are there any specific lab tests that you look at to determine whether someone needs to be detoxified or?
Yeah, so in general, if I do the hormone testing, I always do the estrogen metabolites, right? If you do the estrogen metabolites and you find, for instance, that the 16-alpha-hydroxyestrone is too high, so certainly they have a bad estrogen overload, you can detoxify them. If you do heavy metal testing and they have those, you can detoxify them. If they have other toxic overloads, you can detoxify them. If they have glyphosate, which we can test now, you can detoxify them. So we have things that we can test to actually see clearly that they have something that we can address. Personally, I do that, but also in general, I'm saying even if we eat organic food in this country, the organic food may not be perfect. So we have the right to detoxify anybody, giving them some detox products and clean them up somehow. If they're having symptoms that are not responding to basic treatments, then we have to make sure we detoxify them. We feed them good food, mostly do organic and stuff, but also do a detox program to clean up a little bit.
Mhm. Okay, thank you. What did you take on IgG blood test allergy testing versus IG?
Okay, so that's a good question because I didn't do that. Now, allergists so far they still don't believe in IgG testing, but I do. You know, as you know, I'm an integrative person. I do IgG testing for foods mostly. Why? Because the IgG testing will tell me whether they have food sensitivities or they have true food allergy. If you do the IgE, most allergists would believe that IgE reactions are true allergic reactions. If they have IgG, people say, well, they're eating the food. That's the reason they have the IgG being positive. So they would not believe in that. And that's why they don't test it. I personally do test the IgG and to sort out food sensitivities. Because if your IgG test is greater than 10, then you know that they have some sort of food sensitivity going on. And they tell you that when they eat the food, they have problems, then certainly you want to address that. And we can do sublingual immunotherapy based on the IgG testing. The one IgG that I don't do is IgG subclass 4. There's a lot of people, like Cerex test, I think they do IgA and IgG subclass 4 mixed together to test for food allergy. Well, it turns out allergists will never agree with that because IgG subclass 4 is one of the immunoglobulins that is produced by the B cells for tolerance. So if you're using tolerance as an allergy, then people will not believe in that. That's why I said, make sure that whatever you're using IgG does not include IgG subclass 4.
Okay. All right. Anybody, that's all the questions in the chat. Are you ready to talk about the course you've been working on, Dr. Benoit, or?
Yeah.
Ready to roll?
So, one of the courses will be the Integrative Immunity course, where we can go 3 days workshop. Now, this is just, as you saw, we went really fast over these things, but the course will go deeper and where we can show you exactly everything that needs to be known about integrative immunity and help you out so then you can implement that in your practices and be able to take care of the patient. As such, you become part of our community too. We do have a Pro network where we have courses, we have books, we have all kinds of things there, videos that people can use to train their patients. So if you become part of our group, then you can use our videos instead of you going create your own. You can use our platform to help educate your patients. So that's one way. We talk about hives. So urticaria, we're going to go deep in urticaria, go beyond everything, mast cell activation, everything that we have been discussing, and bring in complements, bring in autoimmune diseases, all the treatment possible that you can have. We will do orthomolecular I'll talk about supplements, what supplements you can use to help your patients. So all of these will be part of the workshop. So it's a 3-day workshop that we will be doing.
And this
I
is,
haven't put the dates yet, but I think probably sometime end of August or September will be a fair time to do so.
okay. Okay. Thank you. We'll keep everyone updated, and when we get dates, we'll certainly, send it out to our audience.
Right.
Okay. Any little wrap up here, I always like a little summary, a take home point or two.
Yeah, so the take home for this little presentation of the 2 parts presentation we have done, I talked to you about quad pandemic and the theta state. The quad pandemic is that we have an estrogen pandemic that many people don't know. We have an obesity pandemic that everybody knows. We do have the allergy autoimmune pandemic. We have the anxiety depression pandemic, and we have the bacteria virus candida pandemic. So those are the 5 things that are together contributing to chronic diseases that we see around, that many times we take them as in isolation, one by one, to try to fix things, and it's not working. So if you want to help your patient, or you want to solve problems and go to the root cause of the problems, then you have to look at these 5 pandemics and address all of them when the patient comes to you. And all the details is what we have done. And many of the details I have given you diagrams. I have talked about the obesity pandemic, the estrogen pandemic, why. I showed you the CDC 4th report, and then I went into the obesity, show you when it started. I even have a book that is coming called The History of Obesity. So I give you the history of it on it. It's not a long history, it's a 42 years or 40 years of obesity history. So we can quickly hone in on that and understand what obesity is and why and what, and be able to address it. And then we went into the allergy autoimmune pandemic and talked about the allergies, what causes allergic reactions and estrogen reactions and chemical reaction that adds to the IgE reaction that allergies treat. And then we went into the anxiety depression pandemic, and I explained step by step what chemicals are involved in the anxiety and depression pandemic. And then we went into candida bacteria virus pandemic and talked to you about that, and then put it all together, went into the mast cell activation syndrome and what is activating the mast cells, all the things that we have talked about. They activating the mast cells to degranulate and causing more complex presentations of the patient, especially in women.
Okay, great. Anybody else? We got a lot of interesting, great talks. Thank you for being here again, as usual. Dr. Tano is one of our superstars. So we love having you here, and don't be a stranger.
Thank you. Thank you, Dr. Bill.
Okay. Anybody else have any comments or questions? A lot of thank yous. Next week is July 4th, and I am taking off. So if somebody wants to run the seminar, let me know. Otherwise, we'll be back July 11th, and we're going to have Dr. Bob Centenary, who's going to talk to us about hydrogen. You know anything about hydrogen, Dr. Tano?
Yes.
So,
a little bit.
okay. Tomorrow morning, 12 noon Eastern, 9 a.m. Pacific, I will be speaking about the incretins, semaglutide, tirzepatide, I can't even pronounce it, tirzepatide, and there's a new one that just finished a phase 2 study. So if anybody's interested in that, get in touch with me and I'll get you the link. It's with the company Body Site. They talked to us about that. And I had an interesting dilemma this week that maybe I can share with some of you. Last Thursday, we came to the office. We got a new phone system put in, and it has the texting included and the fax machine and all. And last Thursday, we came in and it was shut off. And the reason that was given was that we were, quote, dealing with cannabis, and the FTC is now cracking down on cannabis. Well, we don't deal with cannabis at all, really. And it was, if any of you may have on your websites, we had Full Scripts, which is a supplement distribution company. I'm sure most of you know that. And Full Scripts calls themselves Full Scripts Dispensary. So some genius somewhere decided that dispensary was a code word for dealing with marijuana products, which for some reason, which I thought they were pretty much legal everywhere, the FTC decided that you can't be texting about it. So we're still not up and running. We still have that issue. They told us we have to take down our link to Full Scripts. And I called Full Scripts, and they said, one, they don't even carry even any CBD products, and two, they even have something specifically on their website saying that they don't carry any CBD products. So has anybody had any issues with anything like this? So if anybody have any suggestions, let me know. So that's where we are with that. So next week, I will be off, and all of you have a great holiday.
One thing you may be aware of is Novo Nordisk is now suing small clinics who are selling semaglutide for weight loss. I don't know if you know this.
I heard a rumor.
Yeah.
We heard
So you can't be advertising that either.
Yeah. So we're in big trouble all over the place, right? So
Yeah.
Okay. So anyway, well, we're just going to be talking about the trade name stuff anyway. So the body site, we had them on. Remember, we had the Katrina Lewandowski was her name. They run it's an online sort of lifestyle clinic, and they have a pretty good program. I've used them for a long time. With you can load in patients' names, and they'll automatically they have like 50 or 60 different diet plans loaded in, and they'll deliver recipes and menus daily for anywhere from 30 to 60 days to the patients. So it's quite a bit of a saving, and it's a boon. And they have videos on lifestyle things, and so I'll be talking about them tomorrow. So Sylvia says, get a lawyer and sue for loss of income. The problem is, how do I know what the loss of income was? That's not it's sort of non-quantifiable. I don't, at this point, I don't know. I've had a couple of people call me outside of, either my personal cell phone or on the office, and said they couldn't get through with texting. So I guess I'm fortunate they didn't shut my phone off too. So I was hoping Brad or Kent would still be on, but I guess he's gone now. So I don't know if anybody, if you have Full Scripts on your website, and if you know what it is, it's a supplement like Warehouse. They have a lot of companies, and patients can actually go on there and order supplements that you recommend, and you get a little bit of a commission from it. But they call themselves dispensary. So I guess that's a 4-letter word these days. So anyway, that's that. So any other, Sylvia, have any other advice? If you're on, John, you around?
Everything's beautiful. Great talk. A lot of information. Wish everybody have a good 4th.
How's
Sorry,
it?
Bill, I couldn't find the unmute button, but yeah, I mean, they're the big guys, so it's like, what they always say, whoever has the most money wins.
So, well, the phone company saying that was the FTC, and it was out of their hands. So I called Full Scripts. They said they never had anybody that had it happen to anybody else. They're a pretty big outfit, I think. And I don't know, just every week, once a week, it's something new, right? So So Dr. Benoit, again, thank you so much. Great lecture as always. Everybody else have a lovely holiday week. Try to remember why we're off. Sometimes it gets lost in the shuffle. And John, you'll let us know how the medical school's coming along.
Everything's beautiful. And just throw out in everybody's head, we're going to have a East Coast gathering conference sometime. So in the next 2 months, 3 months, 4 months. But if anybody has any idea of what they want to present, they could either contact you or me on that.
Okay. And we'll get a venue together. We'll get a a definitive date. We'll try to skirt around all the the big conferences if we can. Maybe we should do it during OMED. OMED's in Phoenix this year, I think. Maybe we should do it across the street and see if we can detract some of their crowd.
Whatever you say.
Yeah, come to think of it, I kind of like that idea. So, okay, everybody, thank you so much for being here. I always like to say, bring one friend and we'll double our census.
Yeah, thank you everybody for coming, and
Thank
thank
you.
you, Dr. Bill, for inviting me.
Yeah,
I
thank you.
appreciate that a lot.
Anybody else need a OMED is in Orlando. Okay, well, there you go. That's the East Coast. Here you go, John.
Yeah, well, think about it.
Okay. All right. So all right, everybody, thank you so much. If you have something to present, please let me know. We're always interested in our homegrown crowd presenting their stuff. Till next time, over and out, and we'll see you shortly.
All right.
Good night, everybody.